some thumbs up to make sure that everyone is all right. Perfect. Thank you, Michelle. Yours was the first one that popped up for me. Well, welcome everyone to Access and Beyond. We are going to be talking about quality integrated community safety net systems here in Mecklenburg County. So I want to introduce myself and then I'll kick it off to my co-host today. My name is Shanavia Montgomery, and 14 days ago, so have mercy on me, I started serving as the new executive director of CareRing. If you're not familiar with CareRing, it's a local organization that was founded in 1955 that's dedicated to providing high quality holistic health services to our financially vulnerable neighbors who are in our community that are either uninsured or are underinsured. We are able to accomplish this awesome mission through our 3 comprehensive programs. We have a low-cost clinic, we have a nurse-family partnership program, and our physicians reach out program, all of which are made possible through amazing efforts collaboratively with other local healthcare organizations, our county government, our social determinant partners, and countless philanthropic partners in the community. Don Jonas, who was the previous executive director of CareRing's in the audience, so no pressure for me today at all. And in addition to CareRing, I'm also an adjunct faculty member with the College of Health and Human Services with UNC Charlotte, who's my alma mater. Kicking it off to Carrie.
All right, thank you. Good morning, everyone. My name is Carrie Birch. I'm the director of the Office of Innovation and Strategy with Mecklenburg County Public Health. On a regular day, that means my program works to support programs throughout the department, from grant writing and training and education to strategic business planning. On an irregular day, which we've been experiencing for the past 365 plus days here, been working pretty heavily in our COVID response, of course, and right now get to be on the kind of proactive side of that with our vaccine clinics that we are hosting throughout the community. Certainly in my time with public health, access to care has been an issue that's near and dear to my heart. Certainly work closely with a lot of the free and low cost clinics in the community, as well as having been a member of MedLink for probably most of my time that I've been with public health, which is almost 15 years. So happy to be here with you all. And I think Trinity will be doing much of the heavy lift during this presentation, but there's bits and pieces of some of the access to care data and health disparity data that I'll be chiming in on here and there. So I will turn it back over to you.
All right, well, we can do a quick poll. I'd like to see where everyone is within the healthcare space. If you can let us know what industry within healthcare you represent, that would be great. All right, looks like most folks are from hospital, quite a few from policy or government. Those of you that listed other, if you can come off of mute and share with me where you are or what space you're representing.
Hi, this is Susan Walker. I'm actually with Atrium Health, but I work with Charlotte AHEC.
Thank you.
I'm Zandra Moss, and I work for Developmental Disability Services.
Thank you.
Hello, I'm Patrice Heath, and I am a therapist.
Nice to meet you, Patrice.
Thank
All
you.
right. Thank you. All right, so we're going to go ahead and end that poll.
And on behalf of Renee, I monitored the chat and noticed we have Renee from Department of Social Services in with us.
Wonderful. Thank you, Renee. All right. Okay, so a little bit about this session. We're going to be exploring the integrated healthcare system. We are going to talk about what the current network looks like. We're going to work towards strengthening it together, not only to improve the number of people that we serve, we know that's important, but also how do we do so affordably, equitably, and with a quality expectation that's worthy of the people it's going to reach. So we love to collect data. right? Everyone here probably does it on a daily basis. We've got valuable data, and that should hopefully inform the policies that are going to shape the creation of what we hope to be is an ideal system. So today we're going to generate some really healthy thought content that's going to aid our community leaders in their efforts as they begin this transformative process. If we want a sustainable system, we've got to build it with intentionality. And always throughout this whole process today, just keep in the center of your thoughts the people that we're going to hopefully serve with this new and better system. So as we talk about Mecklenburg County, right, we know that this is a wonderful community, and you probably moved into your neighborhood or your community on purpose. You appreciated the value that it had. You saw the ability to thrive for your family. And we know that Mecklenburg County, it holds a great deal of wealth. It's the center of finance in our region, maybe even the East Coast. And it's home to just about every luxury I can think of that I'd expect of a large urban or metropolitan community. However, it's also home to rising violence. We have increasing challenges around poverty, and those issues are only worsened through affordable housing challenges and food insecurity issues. We're growing at a rate of 2% every year, and so the infrastructure that we're building has to keep up with it. Overall, the quality of life for those who live in Mecklenburg County can drastically vary, and we have to ask ourselves how this happened and why. And how do these challenges contribute to the overall physical and mental health of our most vulnerable neighbors in the community? So as shared, we've got the data. Efforts to deepen our understanding of the state of poverty as it relates to the health and well-being are underway. They've been underway for a very long time. I'm going to turn it over to Carrie, and she's going to share a little bit about the information our county health department collects annually through a number of intense assessment efforts. We can't develop a solution until we clearly understand the problem, right?
And just as a programming note, am I able to advance these slides, or am I going to be?
I believe I am still advancing, so
Okay,
just
perfect.
let me know when you're ready for the next.
Got it. So we have here a quick kind of snapshot, I think, for those of you who even have some exposure to data related to Mecklenburg County. This map is going to look fairly familiar. And you've probably heard the transition of what we call these we call them now public health priority areas or priority zip codes. It used to be referred to as sort of the crescent of need, sort of those areas within our community where we ought to be focusing more of our efforts to improve health outcomes. So here's, and again, it's a little bit, you see the data is from 2012 to 2016. Unfortunately, we can't say that it's changed a whole lot, right? So you look at this map and it highlights some areas where we have folks living that have less than a high school diploma, folks living below the poverty level, and folks living in, this probably should go without saying, but with regard to poverty level, a lot of our benefit programs, the reason that those thresholds are set at maybe 200, 300, 400% poverty level is that the poverty level itself is extreme. 100% of poverty is extremely low. I don't have the table in front of me. It's updated every year, but if you're familiar with those numbers, the basic poverty level is extraordinarily low for, whatever the family size is, 1, 2, 3, 4, 5. So when we look at the poverty level, that's just sort of the tip of the iceberg. And we all know that. I just sort of wanted to explain a little bit more of the data there. And then, we have our hospital locations. And I will say over the past couple of years, there has been some improvements in terms of our kind of brick and mortar access points for healthcare, particularly medical homes. But again, where people have to travel to get their care certainly impacts how quickly and how easy it is for them to get care when they need it. So we know that folks living in these priority zip codes and these public health priority areas lack access to not just healthcare, but nutritious foods, right? We don't necessarily have our Harris Teeters in those areas. And there's increased access to, or increased, I guess, exposure rather to tobacco and alcohol advertisements, and what we call sometimes food swamps. So, right, food deserts are when there's kind of a lack of access to nutritious foods. Food swamps, I've not heard that term, is areas of high density, like fast foods, where you see that sort of strip of McDonald's, Taco Bell, where there's high access to those fast food establishments. And then, you know, so just the walkability of these neighborhoods or the perceived safety certainly impacts how well people are able to be outside and be physically active. You can go to the next slide. And here's some snapshots from our most recent community health assessment. So I'll give you kind of just a blur. So a blurb about our community health assessment for Mecklenburg County. It's done in partnership with Atrium, Novant, and the One Charlotte Health Alliance. So it's a process that takes place every 3 years, where it's kind of a big review of health data indicators and social determinants of health data that we have available to us. But in addition to you know, that review of data, which is in and of itself is helpful, there's also kind of a community engagement portion of that, which is it's priority setting. So that's kind of a key component of this community health assessment process is, all right, here's the data, but, you know, based on this, where should we as a community be putting our efforts? And I think I think I'm jumping the gun a little bit. That's in a slide coming up, but this data that you're looking at here is part of that priority setting process. And I'll go into a little, or part of that community health assessment process. We look at, you know, not just chronic diseases and maternal child health and all of those kind of key indicators. We kind of break them down because we know that these issues do not affect people equally across the board, right? So when you look at obesity, there's certainly disparities. We know that racial disparities exist among, you know, most of our health indicators, but there's also disparities in terms of income, right? You look at obesity, smoking, and folks reporting not getting physical activity. There's similar disparities when you look at those who have a high school diploma or less versus persons with a college education. So again, it's not necessarily that one causes the other, but certainly associations, and it makes calls us to consider, if we're trying to address these issues as health systems, as clinics, as public health departments, that we really need to look at how these issues impact people differently, and our approach should be different based on the populations that we're working with. I don't think it's any news, of course, that life expectancy varies quite differently by race, varies by zip code, and I'm glad to see that the dental access to dental services is highlighted here. I don't see her as part of the group, but one of my colleagues, Sheila Wright with Atrium, is always the one, whenever we're talking about access to care, she's always the one to raise the flag about, you know, dental services need to be right in there, part of the conversation, along with medical services. And certainly that's one we see that low-income adults are 5 times more likely to report not seeing a dentist due to cost. And then moving on to preterm birth. So we have life expectancy at one end of the spectrum, preterm births at the other end of the spectrum. You know, while we have some general improvements in infant mortality, those improvements certainly aren't shared equally among all groups in the county. So when you look at disparities, there still persists kind of significant disparities with infant mortality. And similarly, maternal mortality seems to be something that is stubborn for a lot of reasons that we probably could have several breakout sessions to look into that. Next slide. Oh, and I should have mentioned on the previous slide, the data that we have comes from, that particular data comes from the Behavioral Risk Factor Surveillance System. So that is actually a nationwide survey that's been put out by the CDC. And, it's validated all of those good things that we would look for when we're looking for kind of good data. But we have administered it locally in Mecklenburg County so that we are able to get our own sample size, or our own data related to our own community, versus some areas that sort of have to just make predictions and projections based on data for the state overall. So we're very lucky that our health department has been able to sort of has found value in continuing that survey, and that is a big source of data for us. All right, these health issues that have populated, right? I think for those of us who work in healthcare or near healthcare or somehow related to healthcare, racial disparities are not anything new. I think what we're seeing now because of COVID is that a lot more people outside of healthcare are realizing that these disparities are real, that they exist, and that they mean wildly different outcomes for people based on race, income, zip code. So we talked about food insecurity being one of those, having access to healthy foods. Infant deaths, I spoke about already. Mental health treatment, of course, continues to be a barrier, or continues to be something that we struggle with as a community, just having adequate providers, but also understanding how to access mental health care, and the funding for that, the stigma around that. There's all sorts of different components of mental health treatment that make that a particularly kind of tough nut to crack as a community. Chronic diseases, I think, are the ones that we've sort of always known that we've seen health disparities in, right? Hypertension, diabetes, and homicide deaths, of course. That's one where this year and last year in particular, our homicides in Mecklenburg County were reaching levels that we hadn't seen in quite some time, and certainly impacting parts of our community more than others. Next slide. Okay, so for this group, I think social determinants of health are something that we don't really need to explain in great detail like maybe we did several years ago, but just as sort of a level setting slide here, social determinants of health are those things that impact our health outside of kind of the clinical, what you might consider the clinical care. So economic stability, right? Do I have a job? Do I have a good job? Do I have a job that allows me sick leave, or allows me sick leave to take care of my children if they're sick? Social and community context, right? So you think about medical mistreatment and the values that people have related to medical care. I think wrapped up in this one would also be understanding the barriers, or the impact rather, of folks who do not speak English or speak English as a second language. So that's another sort of social piece that impacts somebody's health. Neighborhood and environment, right? That goes back to a lot of things that I mentioned with food access and having sidewalks or having access to public transportation, where you live and how easily you can access the things that improve your health. Healthcare, again, is a piece of this, right? But what does that healthcare look like? Is it healthcare at a medical home? Is that healthcare at an emergency site that's maybe not ideal for whatever it is that you're there for? The healthcare piece of it is certainly a component, but it's not, it varies widely. And then of course, education being a part of this as well. So not just education as it relates to economic stability, but you think about health literacy, and do I have the information that I need to keep myself healthy? Can I understand the information that I've been given? There's a lot of especially when it comes to chronic disease management, there's a lot of information that, or a lot of things that individuals are expected to kind of manage on their own, which is certainly easier for some than others. So that's kind of just a snapshot of all of that stuff behind the scenes that goes into, how healthy someone is. Next slide.
So there's no denying the correlation, as Carrie has shared, between income and health. If I'm going back to my social work roots, person and environment theory, right? So we're talking about a person and how heavily they're influenced by their environment. So therefore, the problems and the issues that they have really need to be largely understood by all of their environmental influences. The experience that the person has, they're helping shape the way that they view the world, how they think, and how they respond to all of these different stimuli, especially taking into account the daily trauma that we know that's experienced by someone living in poverty. As professionals, during this conversation, I want you to think about how imperative it is that we redesign what would be hopefully an improved macro system as we begin asking what happened to the individual and what do they need to help them overcome the things that they're being experienced on an individual and micro level. A good example that's always used, unmanaged diabetes. It's not simply due to a person's poor willpower, right, and their poor eating habits. Carrie's talked about all of the other things that are influencing them, but rather it's a lack of access to healthy foods or difficulty getting transportation to an available grocer that doesn't exist in your neighborhood because you're in a food desert or a food swamp. Also know that we've all been there, right? People don't just overeat for no reason. They may overeat because they're coping psychologically to, again, all of these stimuli.
I think this was what I was starting to get to before. As part of our community health assessment, one of the key components of that is sort of getting input from the community as to where we should be putting our efforts with regard to the health issues that we're facing. So the most recent priority setting that we did was in 2017. And I will say that the 3 previous assessments that we did pretty much had those same 4 that you see. Sometimes the order changes a little bit, but we've seen striking consistency with where people continue to say the issues, the most important issues are. So this most recent assessment process was mental health came out as the #1 health priority, followed by access to care, then chronic disease and violence prevention. And, really these are listed as separate issues, but you can't touch one of them without also having to kind of touch some of the other ones, right? So within mental health, of course, access to care is a component of that. Similarly with chronic disease, violence prevention certainly impacts mental health, right? So when we were doing this priority setting process, just for your information, we had sent out about, I think, 2,000 surveys where we asked folks to give their input. Those were paper surveys, they were online surveys, they were in English and in Spanish. And, we really made a pretty good effort to, even though it wasn't, a gold standard random survey, the respondents, the demographics of the respondents matched pretty well to the demographics of the county overall. So we were pretty happy with that. We also did kind of a half-day priority setting event. And that was largely attended by kind of agency folks, but a variety of agencies. It certainly wasn't just healthcare, where they got some education on these issues and then went through a priority setting kind of ranking process for each of these. And then lastly, we did these sort of mini priority setting exercises throughout the community where we did sort of a modified hour-long version of that half-day priority setting event. So when we present to you these top 4, I give you that background just to let you know that there was a great deal of effort and, quote unquote, true community input. It wasn't just 10 people who sat around and decided that these were the things. We were really happy with the community input, and then again, how the community input sort of matched the demographics of the county overall. Next slide.
Right. So currently it's estimated that 12% of our county's population is uninsured. We know that that wavers, and we are on the verge of a Medicaid transformation within our state. So we'll see how that number varies in the coming years. But this is slightly higher than figures for the rest of the state, who hovers around 11%. And as Carrie has shared, there are racial disproportionalities that exist, with the Hispanic population having by far the greatest percent of uninsured adults in Mecklenburg County, followed by our Black citizens. Males also, due to a lack of ability to obtain state-funded health insurance during the childbearing years. We know that if you become pregnant, there are many fiscal leniencies within your Medicaid application that allow you to get access to care during your pregnancy so that you have a healthy birth outcome. And then also younger adults tend to be impacted at a greater state as well. So understanding the who is important. It's going to ensure that our interventions that we develop are targeted. If we are aiming to improve health outcomes in specific communities where these issues are more prevalent. So this slide, we want to talk about definitions of safety net systems. I was looking and just found a lot of repetitive language, but I believe this one is pretty tried and true around what a community health safety net should be, or what it was. It hasn't changed much, and this definition is from the year 2000, and it's cited everywhere, even in recent publications. When you read the definition out of total fairness, it's not bad. It's comprehensive, and it defines the populations that are intended to be served and the circumstances under which they should be cared for. So although it's 21 years old, I believe that this definition still stands, or does it need to be revisited? How much of it's still accurate, and how much progress have we truly made if the definition has not changed? So I want to take you to a pretty model system that's out in San Francisco. It's called Healthy San Francisco. It was launched in 2007, and it's actually the nation's first healthcare access program. And it was designed to allow healthcare access to primary and preventative care through medical homes for the uninsured in San Francisco. So a lot of times when we're looking for ideal programs, we always tend to go out west. They're a little bit more progressive than we have been on the East Coast. This program also provides access to specialty care, urgent care, emergency care, lab services, inpatient hospitalizations, radiology, pharmaceuticals, the whole lot. And the objective is to bring universal health care to the city. Healthy San Francisco is not an insurance program. It's important to understand that, but it instead seeks to fill out the gaps and limitations that are created by our current healthcare system in our nation and even within their state. So Healthy San Francisco represents the first time a local government attempted to provide health insurance for all of its constituents. By July 2010, almost 90% of the uninsured adults in San Francisco, over 50,000 people, had enrolled in this program. Before it existed, the city's safety net system, it consisted of hospital systems, community health orgs, clinics with managed care, very similar to our system here. That's what it looked like prior to, but through the creation of Healthy San Fran, a more coordinated system of care now exists. There's more efficiency, there's less redundancy in care, and it's very integrated from the enrollment all the way to discharge if someone becomes eligible for an ACA program or a Medicaid program, for instance. The city of San Francisco chose this innovative solution to evolutionize how they operated that system of care. Lots of participants, upwards of 80%, also reside in their 7 vulnerable zip codes. Sounds familiar, right? So they've also ensured that they've increased the availability of programs for these high priority areas, and they've dedicated resources to increase access and preventative services for those residents. Lots of outcomes, of course. You want to know, why is this program great? Well, more San Franciscans have insurance. Their estimated rate of new HIV infections, it continues to decline. Their life expectancy has increased for all San Franciscans, with the biggest gains seen by Black or African Americans. And their morbidity rates due to lung, colon, and breast cancers, in addition to pneumonia and influenza, continue to decline. And last but not least, they also are reporting that approximately 4%, only 4% of their population does not have health insurance. And they're citing that as an issue with maybe some cultural challenges. There are languages, barriers, cultural issues. You know, we have a system that some people haven't gained trust in to the level that we'd like. So we have to consider that as well.